All right, welcome back to the Hoeflinger podcast, episode 7. It's me and my dad today.
A little
It's
coffee. It's morning.
yeah, a little coffee. It's going to be a nice, a little bit shorter episode today. It's been a busy week, but so I thought we'd talk about what it's like for you, and then kind of from the patient's perspective, going through surgery, from what when people have pain, what that presents as, uh, the different procedures you perform, recovery and or the actual procedure, and then different recoveries, stuff like that.
Well, I think so. Starting from when a patient first comes in to see me, I think the first thing you need to do is kind of adapt to each patient, because I think people are nervous when they come in. They're telling you about something that's very important to them, and they don't know. I think they're sitting in front of a neurosurgeon. They just don't know what to say, if they're going to say the right thing, or so. I kind of guide people through it. So what I do is, certainly I introduce myself and might ask them a question or two about themselves and how old they are, and just kind of break the ice a little bit. And then from there, I'll ask them, what can I help you with? Because I'm there to help them. So I mean, what can I help you with? And I think that opens up things nicely, and then people will start to open up. And I'll ask them, if they go on their own, I let people talk for 5 minutes or so, just to give me their perspective of what's happening with them. Some people don't say much, so you kind of have to guide them. So I'll say, well, let me know, can you tell me where you have pain? And I'll have them show me exactly on their body where the pain is. And I'll ask them, where does the pain go? And I have them just pretend like they have a paintbrush and paint it down their body exactly where it goes. And that gives me a really good idea as a neurosurgeon. If it's a nerve related thing, what nerve is it? Because they're telling me by painting it on their body. And then you got to know how long they've had it, and is it there all the time, or does it come and go? Is it there every day? How long ago did it start? Is it progressively getting worse or better? And then, what kind of treatment have you done for it so far? Have you been through physical therapy? Have you been to a chiropractor? Have you been to pain management? And there's other questions, but those are the main things I try to ask people just to get it started. And I think as you get the interview going, people start to open up to you. They'll feel more comfortable, and then they'll give you some of the other little details that maybe we need to know. And so that's the start of the interview.
And for people that are like maybe intimidated coming into the office or are not sure what to say or what to ask, not just you but just any
Yeah.
doctor, what would your advice be there? And do you have advice for people like writing out questions in advance so you don't forget stuff like
It's a good option, is to, if write down questions and have them. But I think at the beginning, just remember you're there. You're there to get help, and the doctor's there to help you. So you don't want to come in thinking that somebody doesn't want to help you, or you're going to be rushed through it. And if a doctor's going too fast for you, try to slow them down. I often, maybe if I have a busy day and I'm moving too fast, a patient will say, can you just slow down a little bit? Can we go over things a little bit slower? And I'll respect that, and I slow down a little bit. So I think you have to stand up for yourself as a patient, and politely as you can say, can we just go over things a little bit slower, or bring up things that you want to bring up, because sometimes I think a surgeon has a list of things that he wants to know, and that's it. And there's things that you want to get in there, that you want to tell them, and you have to find a happy medium, because there are people who come in who will try to tell me every detail over the past 5 years of everything that's bothered them, and obviously we don't have time to go over all that, and a lot of that isn't important in the final decision. So I have to very nicely and politely say, um, that's good information, but it's not going to help me particularly right now in making this decision about what's going on right now.
well,
So
you're the expert there, and that's where
yeah,
like your experience can come in, where certain things like showing you where the pain goes on
yeah,
their body, that's way more indicative than all these different, they might have
yeah.
been through a ton of, because
And
before they get to you they have to usually get a
yeah,
referral from someone or have tried other
yeah.
stuff,
Well, and
so
I think you have to be flexible as a patient a little bit. I mean, you probably have a certain mindset of what you want to gather out of this appointment, but you have to let the specialist or the doctor seeing you give them a little leeway, because they've been doing this for a long time, and that's their job. And so they kind of know what they need to ask you to get to a point that they can help you. And so you have to be patient with them as much as we have to be patient with you, I think. Um, so then, once you do that, then
well,
go ahead.
to
Yeah.
pause it a little bit there. Well, a big issue is too is just like there's Google out there and everything else. Patients crave information, and um, they'll go somewhere to find it, whether that be Google or YouTube,
Yeah.
and anything that's put out on the internet is not necessarily accurate. So then sometimes you have to unravel patients who come in, their expectations on stuff,
Yeah,
which
you gotta be very, very, very careful because when you're on the internet, because, and I'm not even saying the information's wrong, but it's different. Like, you find a surgeon from Mayo Clinic who does a procedure a certain way, and then you come in to see me and I describe it a totally different way, and you go, well, wait a minute, this is not how it's supposed to go, So you have to realize every doctor is different, every doctor's expertise is different, and we do things differently. So don't go on the internet and find somebody who does it this way and say, I just thinking that's the way that everybody's going to do it,
yeah.
because it's not that's not going to happen.
Well, one quick example of that is people like doing like a lumbar fusion and stuff. You
Right,
can do,
so many different
what is it,
ways.
X lift, A
Yeah,
lift,
it can come
P
from the
lift.
front, from the side, the back,
You can use
um,
rods and screws, right?
or sometimes not rods and screws.
So
So
like every
yeah,
doctor. So that's actually something too, and something you can tell your patients without, if you don't have as much time with them. Something he started several years ago, and I worked on him with, is we create patient education videos for his patients of like personalized procedure videos, because there is so much information, and a lot of times when you're at a medical office visit, you are like, you're in a foreign environment, you don't feel as comfortable. So instead of people going home and looking at YouTube themselves of some other doctor talking,
yeah,
we made videos of just you
yeah.
doing that,
I
and
mean,
that's kind of what
I'd
led to
rather,
social media.
because I'd rather have you listen to me about what I said in the office, how I'm going to do the procedure, than getting on the internet to go hear about how somebody else does it. So we have videos of me speaking to our patients specifically about the procedure they came in to have done, and me explaining it to them. So even if you forgot everything during your office visit with me, it's all in the video afterwards that you can watch. We send it to your cell phone. You can watch as many times you want with your family, or send it to your daughter across country or wherever. Um,
Um, it,
the other thing too to be careful of too, I think, is I get so many people, especially this week, who come in. It's just a recurring theme, but radiologist reads a report and it sounds horrible, and then I go over the films with you in the office, the MRI or the CAT scan or the X-rays, and I'll say maybe it doesn't look that bad, and they say, well, how can you say that? Because radiologist said I have this and this and this wrong, and so there's always a different interpretation of how a radiologist will read a film based upon how a surgeon will read a film as far as surgery goes. I can look at certain things on an MRI and see if it's significant and do you need surgery or not. But you got to be careful about reading these reports, because it'll drive you crazy. And then the surgeon says something totally different. So many patients come in expecting surgery because they think their report sounds horrible, and their primary doctor read the report and thought you needed surgery. And then you come to me and I say, really, it doesn't look that bad and you don't need surgery. And so it's a big problem, I think, for patients, is this disconnect where they're coming in with an expectation and then I change that expectation. And it's only because, I have a certain way as a surgeon looking at MRIs to talk to you, look at the MRI and know, do I think you need surgery or not? It's not based just upon how a radiologist reads a report. So that's something else to be careful of when you come in for an office visit.
yeah, and so I'll also touch on a couple of things. So some misconceptions I think too is like surgeons always want to do surgery, and surgery is just gonna is will magically fix stuff. So to address a couple of those, why don't you just talk about your philosophy of care? I think some people would be surprised when you tell them like, no, I don't think you should have surgery, or the trade
Yeah.
off. Sometimes we'll touch on this too of when you're very old.
Yeah.
Because I know your philosophy of care is usually surgery is a last resort, which people definitely don't have that opinion on surgeons or general
Well,
conception.
just from my world, so I think you can prey on people. I mean, there's so many people come in pain who will really do anything because they want to get out of pain. So I mean, you could operate on people all the time if you wanted to, because the radiologist will always dictate something abnormal, right? So I can always find something in the report that's to justify, say, this disc looks abnormal, we should operate on it. And patients, I don't think, I mean, they just want to feel better, so they're going to trust you. And that's where I think back surgery and spine surgery gets a bad rep, because so many people get potentially unnecessary surgery at times based upon a radiologist report. Um, so I think most surgeons are going to be of the sort that they're going to. It's not our goal to operate on you. I mean, I do plenty of surgery in the end, but I want you to come in and feel better at the end of the day. I don't want you to come in at your month visit and say, I don't feel any better. Now what do we do? I mean, I don't want that either. So I try to really pick people that I feel surgery will help, and we always will try, if there's somebody has a deficit, or they're becoming paralyzed, or something's really significant, you may move on to surgery earlier, but it's always wise to start with a course of physical therapy. I mean, I see people all the time with narrowing of the spinal canal and pinched nerves, and you put them into therapy, and they come back 6 weeks later and they feel 80% better. So therapy is always an option. A lot of people go to the chiropractor, and I don't have any problems with the chiropractor as long as it's helping and it's not hurting, and it's done in moderation. So I think that's fine. Pain management can be a way around surgery, especially in somebody who is not a good surgical candidate or they're elderly. Pain shots to your back can be helpful, or to your spine. But I think surgery typically is the last option, unless somebody's been through all those things already and they have something that surgery will help with, or if somebody is just in excruciating pain, they have an obvious problem on their MRI, and it's just interfering with their life on a daily basis. You can always move surgery
Yeah.
up the ladder.
Well, we're talking about elective surgeries, obviously.
Yeah, elective surgery, not emergency surgery.
So you want to explain just what elective surgery is quick?
Yeah. So we're talking about office visits. So if you say you have pain in your back and pain down your leg and you've had it for 2 months, and you go see your regular doctor, and maybe you tried some therapy already and it hasn't helped, or maybe not, you get an MRI, it shows like you may have a pinched nerve, then they'll send you to a neurosurgeon, me, to evaluate you. And so that's an elective type of thing, right? You go through your regular doctor's office and then you get referred to me, for me to evaluate, as opposed to like if I'm on trauma call, or I'm on call for the week and someone comes to the emergency department, they have sudden onset of pain in their back down their leg, they have a huge disc herniation, they've got weakness of their leg, then that may be more emergency surgery. Or then there's trauma where you have head injuries and back injuries and from car accidents, those are emergency cases. But today we're kind of talking about the office visit electively.
Yeah. Well, that makes up, especially at this point in your career.
Like, the majority of what
of what you do. And it's not, it's because it's not like you just treat your patients that way. Even my mom, your wife, she got back surgery earlier this year. And I remember the other year, she wanted you to look at her films, and she almost wanted you to just say like, oh, you should need surgery now. And you saw like a slight issue so far, but you're like, until it worsens, it's probably not something. So it's not like, so you practiced that too. And I remember that was, she was annoyed by that, because she just, even though she
goes, are you saying there's nothing wrong with me? I mean, read my report. And then there we go. And I said, Cindy, I read your report, but I mean, it's not as bad as it sounds on your report. And you're not quite at the point that you should have surgery, but she was in pain, just not, she could still go for walks. She just wasn't feeling, normal.
Well, I think,
but then it progressed to the point where she really was interfering with her life, and then we got a new MRI. It was worse, and then that was the time for surgery.
Yeah. Well, no, I think sometimes it's wanting to be heard. There's definitely, I think that's a big thing in healthcare is, some people feel dismissed.
It's true
at different times, so you have to hear.
Well, and those are the hardest offices, because I can't tell you the number of people come in with horrible pain, and I can't help them, and they read their reports and they think I'm not. They think I don't want to help them. They think I'm just not, competent to help them. And they leave sometimes disgusted even, and I can't do something unethical. I'm not going to operate on somebody if they don't need surgery. And so there are people out there who just, they're in so much pain, they don't know what else to do, and they want you to do anything you can do to help them. And I mean, if I can't do surgery, I can't change that.
Yeah.
And then they want to know, you can't just, so you're saying you can't help me and I have to live like this. I'm not saying that. I'm just saying, me as a surgeon myself, I can't do surgery to fix you, and I don't know what else to tell you to do if you've already been through all those conservative measures. There's always a second opinion. I encourage people to get second opinions if that's what it takes, and you just have to hope the next surgeon is not unethical and does the proper thing.
Well, I think that's the issue with stuff too, is if you go to enough surgeons, eventually you'll find somebody. Yeah, you'll find someone who says, okay, they'll do surgery. We can do surgery on this. And the reason he's saying you can't do surgery is like, there's a very, very high, like almost like 95, 99% chance it's not going to help them. And that, like, there's a small.
Well, you mean in that group of people where I don't think it's going to help. But, there's another way to it too. I always tell people, I mean, I don't know it all, right? I'm not a know-it-all. So I can just tell you from my experience as a neurosurgeon for 25 years, I don't think surgery is going to help you. But that doesn't mean there's not another surgeon out there who's seen 100 people just like you and saw MRIs like yours, and he did this procedure and it helped. So sometimes you got to tap into other people's experience. I only have my experience, and so there's another surgeon who's had different experience with symptoms like yours. And so it doesn't hurt to go to somebody or two more people just to see if maybe they've seen something that I haven't, that they found that helps. So I'm not saying that ruling surgery out 100%. I just have to realize when a surgeon says know to you about surgery. They're only doing it from their individual experience basis. It's not,
And what
doesn't
they
mean,
think is they're
yeah,
trying to they're giving you
yeah,
their expertise and trying to
right,
do what's best for you.
right.
But yeah, also different surgeons, some people, like there's stuff that's more specialized than the stuff you typically do, so then someone would have to go somewhere else.
Yeah, if there's something
And
beyond what I normally do in my normal practice, and I will refer them. If it's something specialized to the brain or the spine that's beyond what I normally do, then I'll refer them to U of M or Cleveland Clinic or somewhere like that to see a specialist, even a specialized neurosurgeon who just focuses on that specific problem. I mean,
yeah,
there
there's
are
so many.
surgeons who just focus on one specific area of the brain or spine, and they do very complex surgery. And so obviously they're more qualified than I would be because they do that all the time, and I don't do those specific surgeries. So you got to know your limits as a surgeon, I think, as well, which
Well, because
is
I think that's something too. People would think like neurosurgeon, that's already very specialized, and
right.
people, brain and spine surgeon.
Yeah,
There's they think, oh, this person knows everything.
yeah,
But then there's multiple subspecialties within
yeah.
neurosurgery. You can get way more
Well,
specialized.
and in the end, it can't be an ego game. You can't. I mean, I obviously have to have a little bit of ego to be a neurosurgeon, but you can't be egotistical because in the end, it's about helping you feel better as the patient, and it's not about my ego that I can do a surgery. So you have to. I mean, I learned a long time ago to differentiate the two, and I have to do. I always think about it, if it was my wife or my son, and they needed this surgery, and I don't do a lot of them, I'd send them right off to the specialist. So I mean, you got to think of things as your own family, really.
Yeah. Um. So yeah, moving on. So what
So we
happens?
looked at the films in the office. After we look at the films in the office, then I'll talk to you about what I think you need to do. And if it's surgery, then we sit down and go over in detail what the surgery would entail. Really, that's the time that I let people ask all the questions they want to have. And a lot of people have a whole list of questions on a piece of paper, which is great. And we try to take the time to answer as many of those as I can. And then,
Well, and
and then I give them the video so they can watch all this again at home.
yeah. It's just back to the office visit too.
Okay.
Is when someone who would be a candidate for a good fit for surgery, with when uh, you don't tell people too, like from like what I've all the times I've been there, and when we set up the flow so we can text out the video and other stuff, you don't say like, hey, like you got to make a decision right now. You
No.
say, hey, go home, discuss this with your family, go over
Yeah.
everything I told you, go
Yeah.
watch the video, share that with, and
Yeah.
that's the whole point, is because you want people to be. Some people don't fully understand what they're like doing with surgery and stuff. I mean, that's another reason we made the videos so people could
Yeah.
fully understand their surgery and be informed about their healthcare and being able to make decisions that are best for them.
Yeah, I mean, I think if you ever go in and you feel rushed into surgery, like you don't have your questions answered and you're just being rushed into surgery to make a decision that day, um, that's not how, I mean, that's just not how I do. I always tell people, and you don't have to make a decision today or right now. Go home and think about it. We'll give you a number to call back. If you want to come back and see me for another visit and bring your husband or wife or family, I'd be happy to go over everything again because, you should feel comfortable with the decision. I tell them to watch the video. And I'd say 90% of those people who go home and think about it will call back and schedule surgery. But the wrong thing is to try to tell somebody, okay, you got to make a decision right now. Do you want the surgery or not? I got to get going. I get another patient. So that's not what you want to happen in your visit. I wouldn't think. I wouldn't
Yeah.
want it as a patient. So I try not to do that.
And the only reason we talk about the videos, that's something you had thought about like right around when Brian died. Then you never really did something with it. And then I
Yeah.
was in college. That was something too, like I do for other doctors, because we get so many so much positive patient feedback on these personalized videos
Yeah.
that they share with their family members, especially through COVID, people that might not get to meet the surgeon.
Yeah.
So I mean, I think that you have the whole flow with that, because then you talk about all the other stuff too. Because a lot of people, the conception there too on some patients, they're like, I don't want to see the surgery and stuff. Like you detail the surgery, like using MRIs and everything else, and we've shown stuff like that on social. We started doing. That was kind of the original idea of wanting to put why we started putting stuff on social media. It's like, okay, patients like these so much, let's kind of put out some
Yeah.
other general education of you explaining MRIs to people, or stuff like that. Because a lot of people say you're good at talking in layman's terms and articulate things.
And we don't show the actual surgery. It's just about me. It's just a recreation of me talking to you in the office. So, I mean, I just explain an MRI that's representative of yours again. I use models to explain how we do the surgery. I'll show you sometimes what the films and a typical patient's had a fusion with rods and screws would look like afterwards. So as much information as I can give you in there, I do. but it's not actually showing the blood and gore or anything like that of
Yeah.
surgery. Because some people will say, I didn't watch the video because I didn't want to see it. It's not of the surgery. It's
Because
just
you
of me
realize
talking to you.
people
Yeah.
care about all the other stuff so much more. That's what we like. People want to know, like, what is it that what are you seeing that means I need surgery? So like the
Yeah.
MRIs, the symptoms and stuff. And it's obviously just a representative one. It's not their specific
Right.
one. Talking about what the actual surgery you do, like so you might remove a bulging disc or something else. Um, and then it's talking about the recovery time and what recommendations you have.
Right.
Each surgeon recommends like lifting different amounts after
Right.
surgery, and most surgeries, you're gonna get better for like 6 months to a year after. Um, but if you, I mean, you can check out the videos of any of the surgeons we've done. I've done videos before. It's amm.media, and if you go to the doctors, there's a couple different types. We have orthopedic surgeon, urogynecologist, couple neurosurgeons. But I've done doing that. It's I don't know if you've never seen. I think they're pretty good for even people
Yeah.
who.
And it's important too. I think, like, a lot of people get online on the internet afterwards and say, well, what should I be doing after my lumbar fusion surgery? Well, again, every surgeon's different. So that's why in my videos, I tell you, me specifically, here's what I want you to do, how to change your dressing, what to lift, what activities, when you can drive. And what I recommend to patients can be different than the next surgeon. So that's what I like about the videos, because it's my regimen that I'm talking to you about specifically, and not you getting that information from other surgeons online.
Well, in
You
the
know,
it's like us doing this here, um, because I realize that's his expertise of knowing in medicine how that operates, and then where I come in is no one likes to read stuff anymore. You get
yeah,
these long packets for
yeah,
like you'll get like a 12-page packet, and it's you grab the packet, then you maybe set it at home somewhere, but then you have to look through, and people don't like doing that as much. We're so used to watching videos, like going on, like
yeah.
if I need to look up how to assemble like a new piece of furniture, I guess because of my age and generation, I don't look at the instruction manual. I usually do like a how-to video on YouTube.
But it's crazy too. Like, I'll see people who have been out there, say they had about a back pain, they went to the emergency department, and then when they come in to see me as a patient, electively, they'll show me, well, I went to the emergency department. That's what they gave me. It's like 25 pages of just, I don't even know what's in it. I don't have time to look through it all, and it's hard to even find what they did because there's so much extra stuff in there you don't even need. So
Yeah,
it gets carried away. All the stuff they print out, to give you to read, and
yeah.
just
Okay.
all generic stuff too. It's just generic.
Yeah. So after the office visit, someone has gone home. They've talked to their family. They decide they want to proceed with surgery. They get
Mhm.
that scheduled. Then what's like actual surgery? That's usually the shortest part, right? And or like surgery day,
Yeah, I
I
mean,
should say,
so
not.
at some point you have to come into like a pre-anesthesia visit, and they kind of go over you, do an exam, tell you what to do. Like, the night before, you have to scrub your back and take a certain bath and things like that. And then obviously the day of surgery, like if your first case, if it's my first case in the morning at 7 or 7:30, you got to be there like at you know 5:30, 6 o'clock in the morning to the hospital. And people who live 2 hours away, I mean, I'll have people who are in their 70s and 80s, and they had to get up at 3:30 in the morning to drive to the hospital. So it's a big deal. So I always try to be on time and respect that they've gotten up early to come in and have this done. And then I always stop, always before surgery, to talk to the patient, ask them if they have any last minute questions about the surgery. Sometimes I haven't met a family member, so family members will be there that I didn't meet, and I'll introduce myself and see if they have any questions, because a lot of times they weren't at the visit, um, and they didn't watch the video, and so they'll have a few questions. And then from there, the patient gets taken back to the operating room, and anesthesia has to get you to sleep. So that takes a little bit of time, and then we have to position you on the operating table. And then, surgery itself. Once you're on the operating table and you're asleep, and we clean everything up with sterile prep. Surgery can take anywhere from an hour to 5 hours, just depending on what surgery I'm doing. And then once I'm done with surgery, then I leave the room. I'll have the nurses call to put the family in a room. I'll go out immediately and talk to the family, let them know how surgery went, answer any questions, tell them when they get to see the patient. And then from the patient's perspective, anesthesia has to wake you up a little bit in the operating room, get you off the operating table, and then they'll take you into the post recovery room, where most people are there for an hour or two. If it's a same day surgery, they let you wake up, start eating, drinking, walking. You can go home in an hour to 2 hours to 3 hours. If it's stay overnight surgery, you'll be in recovery room for a couple hours, and they get you up to your room, and then that's where the nurses kind of take over, and the nurses will gradually help you get out of bed. Hopefully later in the day, start eating, control your pain that you may be having with pain medication. Typically, I'll see the patient the very next morning, and I would say 90% of my patients go home the next morning. So I'll come in and see them. So the other day I had 3 patients in the hospital from the day before. So Jenny, my physician assistant, I went in and we saw each patient before we went to office. Office started at 7:30. So we go to the hospital, see the patients. I'll go in, talk to them, see how their day went, see how the night went. We'll look at their dressing. If it needs to be changed, we'll change it, check their strength, make sure they're doing okay. And then just tell them how the day will progress. They're going to get you up a little bit more this morning, eat breakfast, maybe lunch. And if you're doing well by late morning or early afternoon, you can go home. Some people are ready to go right when you walk in, so they'll be out of there by 8 o'clock. And then, I reiterate all the instructions about going home and let them know it's all in the videos to watch the video. Plus, on their discharge instructions, we write down, certain things we want you to know: how to change your dressing, when to shower, when you can drive, how much to lift. So we put all that in written form plus my video. So as much information as we can give you when you leave the hospital, so you're not going home wondering, what do I need to do
Yeah,
next?
the more verified
Yeah.
information you give that's directly
Yeah.
from you as a source
Yeah.
versus
And we have
them
a nurse in
picking
the
up
office
something
every
else.
day, 5 days a week, who's very good. And so we always say you can call her too, any questions you have, and people do call. So we try to give every avenue we can. So when you have questions, you're not sitting out there wondering what to do. And that's something that you should ask ahead of time. After surgery, what do I do? Like, how will I know what to do? Will I have written instructions? Can I call somebody? I mean, that's all important stuff to know. And so we try to hit every avenue to help you after surgery.
Yeah.
Yeah.
And then, so now they've had
Mm.
surgery. Do you want to talk about like the typical recovery, or like or not recovery per se, but like, so you usually see people in the office, like anywhere from 2 6
Yeah.
weekends,
So it just depends.
3 6
if it's
months.
a neck or back surgery, typically I'll see some people at 2 weeks, but typically I see you at a month, and then I'll do a 3 month visit. And each of those visits, obviously, I'll examine you and look at your incision, but also talk about how to increase your activity. If you need physical therapy, I usually start that at a month, and then answer any questions that you have at that visit about things that you're wondering. And so, if you've had a bigger surgery or a fusion with rods and screws, I'll typically see you out to 6 months and a year or two. So a little extra visits for those. If you've had a brain tumor removed, or your trauma from the hospital, it just depends. I mean, I usually, when I have you come back in after removing a tumor, I'll have you come in 2 to 4 weeks after surgery with a follow-up CAT scan to make sure there's no new changes on the head CT. Go over, activity limitations and restrictions. If it's if there's ongoing active treatment, if it were a brain tumor that needs to continue to be treated with radiation or chemotherapy, typically I'll see people out to 3 to 6 months as well. And then traumas, it's all very similar, but traumas to your back or your brain, I mean, typically it just depends how you're doing. I mean, if you're doing really well, I might see a month later. If you really need close follow-up, I might see every week for a few, 2 to 4 weeks. So it just depends on the individual patient.
Yeah. So, but and that's just to make sure everything has went well, is going
Yeah.
well. They know
Yeah.
everything's
But you
good.
got to have
So
context in the office too. Like, obviously things can happen. I can see you one day and not going to see you for a month. And all of a sudden, 3 days later, you've got leakage from your incision, or you have a bad headache, or you're having increasing pain, and you can't wait a month, obviously, right? So I always tell my patients, if something is changing, it's getting worse, you don't have to wait a month to see me. You call the office, we'll get you in. We usually get you in right away, either with the nurse or my next office when I'm there. And always, always, always tell the people, that they can call our office and the nurse can help you. If it's a significant problem that she can't handle, she'll call me, and we always have you come in no matter what. So
yeah,
that
the normal follow-ups are just for people that
are doing
smooth.
fine, right?
Yeah,
Yeah.
it's going smooth and just double checking everything. But yeah, I think that breaks all that down. That's a pretty good detail for people,
Yeah.
and kind of gives the perspective. I think most people who are patients, they see it from their side. They don't necessarily see from the doctor's side. But I think one
Yeah.
good aspect that you talked about was how you might. I mean, you have to remember everyone's a human, so like some days you might be busy and you have you've got other stuff going on in your life, and all of a sudden you have 40 patients and
Right.
it's tight, and then you might go into someone and you're not trying to like not let them speak fully,
Right.
but you think you kind of like can see you don't need the additional information to make a diagnosis
Yeah.
necessarily, and so you have to. So that's a hard thing about being a surgeon, you balancing that, which I
Well,
thought
because
was
you don't want to
important. You
piss
said,
people off, obviously, because they're there. They have feelings. They want to get everything out that they want to say. And when I cut them short a little bit, it's dicey, but it is true. But my bad day shouldn't represent you having a bad day at your visit either. And so I try to always remember that and try to
well,
slow
and
down. But
they had to come check in. They had to schedule a check
right.
in and do all that, and then you come in. So for
Yeah.
people, that's just like any medical office visit.
Yeah.
Like when you go somewhere, and then that someone comes in quick.
Yeah.
But
So
anything else?
no, I just say, just, when you go to an office visit, ask questions. You shouldn't be shy to ask questions. That's your right as a patient. But also listen. I should listen, but you should listen too, because you have to kind of give the surgeon a chance to give you his perspective, and he's often looking at it much differently than your family doctor or a radiologist would have looked at your MRI reading or your study that they're going over. I'm just talking about neurosurgery specifically, but
Yeah. And if there's anyone, I don't know, we talk about it some, but if you are interested in any of like neurosurgery and kind of some of that stuff, and you haven't seen him on social media, the social media side, it's at Doctor, all spelled out, Doctor Heflinger, and or you can just look. We put all the links in like, the description of this,
yeah,
but we got a ton of videos like short form videos and some other ones explaining different things, like how does a good one I think is how does different nerves being affected, what does it present as, like pain down the buttocks or if it's down the
yeah,
front side, those all connect to different
right,
nerves. So I think we have a lot of good
yeah.
stuff there too.
But kind of a short podcast day, but we thought it'd be good just kind of go over the patient experience, like what to expect from an office visit. And then obviously it's based upon my opinion. Obviously every neurosurgeon's kind of a different style and a different way of doing things. But just hopefully this maybe helped if you have an upcoming office visit with a doctor.
Yeah, just
Yeah.
and maybe just get you thinking about different things, or
Yeah.
just because I think that always try to get as much information as you can from the source, because every surgeon is gonna there there's no best approach in neurosurgery or any surgery. There's different fields of thinking,
Yeah.
and then within that there's doctors or the surgeons, they've seen what works best for them. Like you usually tell people don't lift more than like a carton of milk weight
Yeah.
wise,
The milk
but that's all. Someone might describe it a little bit differently or different stuff like that. So it's all, that's just expertise. That's your experience of what's worked well for your patient.
Yeah.
So I think everything is pretty personalized.
Yeah.
But thank you guys for listening, and as always, let us know if you have any topic suggestions, and let us know what you think of the podcast. Thank you.
Have a great day.